to the WHO Africa media briefing, which is taking place in collaboration with the APO group. First, some housekeeping. You can listen to the briefing today in either French or English. To do this, please go to the bottom right-hand corner of your screen, click on the globe icon and select your most preferred language. François?
Oui, bonjour à tous et merci de vous joindre à nous pour cette conférence de l'OMS. Si vous souhaitez écouter la conférence en français, merci de cliquer sur l'icône en forme de globe située à droite de l'écran.
Merci. Joining us today from Brazzaville is Dr. Mashisho Moeti, the WHO Regional Director for Africa. And Dr. Moeti will introduce our remaining panelists.
Good morning and good afternoon to everyone. Bonjour et bon dia. Welcome to this press conference on the COVID-19 resurgence in African countries and the circulation of variants of concern. I'm pleased to be joined for this conversation by two veterans at the forefront of the response to many outbreaks and of genetic surveillance in Africa. Professor Jean-Jacques Muyembe, the Director General of the National Institute for Biomedical Research in the Democratic Republic of the Congo, and Professor Pontiano Kalebu, Director of the Uganda Medical Research Council and the Virus Research Institute. Welcome, Prof. Muyembe and Prof. Kalebu. Thank you both very much for making the time to join us. I'm also, of course, joined by my team who will respond to questions. Across the African continent, more than 5.4 million COVID-19 cases have now been reported and 141,000 people have sadly died. The speed and scale of Africa's third wave is like nothing we've seen before. Cases are doubling every 3 weeks compared to every 4 weeks at the start of the second wave. Almost 202,000 cases were reported in the past week, and the continent is on the verge of exceeding its worst week ever in this pandemic. With the rampant spread of more contagious variants, the threat to Africa rises to a whole new level. Among the 14 African countries now in resurgence, 12 have detected variants of concern, including 9 with the Delta variant. As WHO was supporting countries to track variants in coordination with a network of reference laboratories. So far, 24,000 samples have been sequenced in Africa. We recognize that this needs to rapidly expand. The Alpha and Beta variants of concern have been reported in 32 and 27 countries, respectively. Alpha is dominant in the northwest and central parts of the continent, and Beta is more often reported in Southern African countries. Both of these variants are more transmissible than the wild-type variant. The Delta variant of concern is the most contagious we've seen. It's been found in 16 African countries so far, including 3 out of the 5 countries reporting the most new cases. In South Africa, it has overtaken the Beta variant to become dominant, and Delta may be up to 60% more transmissible than other variants. Increased transmissibility means more cases, more hospitalizations, and a higher risk of overwhelmed health systems. Some evidence also suggests that the Delta variant is linked to people experiencing longer or more severe illness. This is consistent with devastating news being reported in countries of scores of patients dying due to a lack of oxygen supplies. Our estimates indicate that oxygen demand is currently 50% higher than it was this time last year. As WHO, we're working around the clock to improve access to oxygen. Procurement is underway of thousands of oxygen cylinders to support Uganda, Zambia, Namibia, Zimbabwe, and Rwanda, among others. In the coming weeks, we'll have a regional stockpile of oxygen concentrators, rapid diagnostic tests, and other crucial supplies available to quickly deploy to countries in need. We're also supporting countries to increase oxygen production. With WHO's guidance, countries are taking action to curb the rise in cases. All countries in resurgence in the region have put limits on people gathering to help with physical distancing. Kenya, Namibia, and other countries are implementing restrictions in hotspot zones. They are using nuanced, risk-based approaches informed by the local epidemiology in an effort to avoid nationwide lockdowns that we know cause great harm to livelihoods, particularly for low-income households. We're seeing globally that vaccination offers a clear path towards ending devastating surges of severe cases. Yet, just over 1% of Africans are now fully vaccinated, compared to 11% of people globally, and over 46% of people in the United Kingdom and the United States, for example. While vaccine supply challenges persist, dose sharing can help plug the gaps. We are grateful for the pledges made by our international partners, but we do need urgent action. Africa must not be left languishing in the throes of its worst wave yet. Studies of the Astrazeneca and Pfizer vaccines, which are being shipped to African countries by the COVAX facility, show that 2 doses of these vaccines provide high efficacy against severe infection and hospitalization or death with the Alpha, Beta, and Delta variants. Vaccines authorized by WHO for emergency use have proven millions of times over that they are safe and efficacious. And I again urge all national and regional regulatory authorities to accept these life-saving products. To monitor and address any performance gaps in vaccines, we've established the African COVID-19 Vaccine Effectiveness Network, and WHO experts are on the ground providing guidance to countries in the rollout of COVID-19 vaccines, as well as supporting sequencing to track variants. Finally, I'd like to add my voice in condemning the attacks on 3 humanitarian employees of Médecins Sans Frontières in Tigray region in Ethiopia last week. They are among 12 humanitarian workers killed since the start of the conflict. The people of Tigray are in desperate need of humanitarian assistance. An estimated 5.2 million people have been affected by the conflict, including more than 2 million without sufficient access to basic services. 54 WHO staff are on the ground in the region, and their safety and security is our top priority. In closing, I'd like to say that while variants may be more transmissible, it's important to remember that people spread this virus. Every person plays a role in stopping COVID-19 transmission by getting vaccinated as soon as you can, by wearing a mask, by physically distancing, and frequently washing your hands. These basic prevention measures are still the key to ending this pandemic. So I thank you once again for joining us, and I look forward to our conversation.
Thank you, Dr. Moet. Yes, indeed, we all have a role in limiting the spread of the virus on the continent. Professor Muyembe, please, can you tell us the impact of the new variants on the response?
La présidente. C'est un plaisir pour moi donc de prendre part à cette conférence de presse. Et le résumé du docteur Moiti est vraiment parfait et ça reprend exactement la situation en Afrique et principalement en RDC. Et comme vous savez, notre lutte contre la COVID-19 en RDC a commencé en fait le 10 mars 2020, lorsque le premier cas a été détecté chez un voyageur. Et après, l'épidémie était en fait une épidémie de voyageurs, donc une maladie importée pendant au moins 1 ou 2 semaines. Et puis après, ces voyageurs ont infecté leurs membres de famille et l'infection locale a commencé. Et puis l'infection locale a pris le dessus sur l'infection des voyageurs. Et nous avons connu comme ça une première phase aux vagues. Et le grand défi pendant cette première vague, c'était donc le diagnostic et le traitement. Et puis après, on a eu une accalmie et puis une deuxième vague qui a commencé. Et déjà, nous avons une expérience dans la prise en charge, n'est-ce pas, des malades. Et la mortalité chez les personnes hospitalisées est descendue de 11, n'est-ce pas, à 2%. Surtout grâce à l'utilisation de l'oxygène et d'autres produits. Et puis, on a eu encore une accalmie et la troisième vague maintenant qui a commencé. Et la troisième vague, bien sûr, le grand défi, c'est la survenue de variants, la survenue de variants et également l'utilisation, n'est-ce pas, du vaccin. Alors, en ce qui concerne la survenue de variants, nous avons dans notre institut les capacités de séquençage du génome complet, n'est-ce pas, du virus. Et d'ailleurs, l'OMS vient donc de désigner notre laboratoire comme un laboratoire qui va supporter donc ces séquençages pour certains pays africains qui n'ont pas cet équipement. Et nous, quand on voit de plus près, quand nous voyons donc la semaine du 24 au 30 mai, c'est le variant sud-africain qui prédominait, suivi du variant Delta indien. Et quelques semaines plus tard, donc la semaine du 31 mai au 6 juin, c'est la prédominance maintenant du variant indien. Et au moment où je vous parle, le variant indien représente à peu près 84% des variants qui circulent en RDC. Et comme a dit Madame Moueti, ce variant est vraiment un variant oui. Alors, je vous montre ici, je vous projette donc la diapositive qui montre donc l'évolution, n'est-ce pas, des variants en RDC. D'abord, il y a vraiment une grande diversité de variants, bien sûr, mais les variants le plus significatif pour nous, donc, c'est le variant sud-africain et le variant indien, en dernière diapositive. Si on peut nous donner... Oui, voilà, c'est là. C'est là. Ça passe? Oui, voilà. Donc,
yes, we can see the screen. Go ahead, Prof.
OK. Donc, à votre droite au-dessus, vous avez donc la semaine du 24 pour là. Oui. Voilà, donc, ça passe, ça va? Oui, donc, la semaine du 24 au 30 mai, vous voyez donc, c'est le variant sud-africain, le B1351, qui représentait à peu près 31%, et le variant indien en bleu représentait à peu près 32%, et d'autres variants, voilà. Alors, maintenant, à gauche, le 31 mai au 6 juin, le variant indien représente 79%, hein, suivi donc du variant sud-africain. Et ici, au mois de... Ici, donc, du 7 au 13 juin, le variant indien représente maintenant 84% et le variant sud-africain ne représente plus que 1,43%. Et les autres sont donc d'autres variants qui n'ont pas d'intérêt. Voilà donc l'évolution des variants à Kinshasa. Et sur le plan clinique, nos hôpitaux sont donc débordés. Il n'y a plus de place pour les hôpitaux pour la réanimation. Et également, les morgues sont donc débordées. Et ces variants, en tout cas, fait beaucoup de dégâts. Moi, personnellement, j'ai vu que beaucoup d'hommes politiques sont donc infectés et décédés. Et également, les professeurs d'université. Nous avons perdu beaucoup de professeurs d'université et l'évolution de la maladie est vraiment très rapide. Et si ça continue à cette allure-là, ça va être vraiment une catastrophe pour la RDC. Alors, en ce qui concerne la vaccination, nous avons planifié 498 sites de vaccination, mais pour le moment, il y a 268 qui sont fonctionnels et sur 8 provinces. Alors, pour le moment, bon, on a vacciné jusqu'à présent 5000 personnes. Bien sûr, ça ne représente rien pour un pays comme la RDC. Et nous faisons toujours face, n'est-ce pas, à une certaine réticence de la population à accepter la vaccination, surtout comme nous n'avons qu'un seul type de vaccin, Astrazeneca. Avec tout ce qui s'est passé autour de ces vaccins, ça a créé beaucoup de méfiance auprès de la population. Mais je pense qu'avec la gravité de cette troisième vague, la population, il y a de plus en plus d'engouement pour aller se faire vacciner. Mais malheureusement, nous n'avons plus de vaccins parce qu'une grande partie de l'eau que nous avons reçue de l'opération COVAX a été redistribuée à d'autres pays. Et donc, nous devons faire maintenant des efforts pour avoir le vaccin et vacciner. C'est la seule solution pour sortir du bourbier dans lequel le pays se trouve et le monde se trouve, c'est la vaccination. Nous avons vu aux États-Unis, nous avons vu en Grande-Bretagne, etc. Et si, en plus de cela, nous portons correctement les masques, nous gardons la distanciation et nous lavons les mains fréquemment, tout ça mis ensemble, c'est la seule façon pour maîtriser cette épidémie en Afrique. Merci.
Merci beaucoup, Professor Muyambe. Indeed, the evolution of the variant is worrying. Professor Kalibu, can you please tell us about how the Delta variant is driving surge in cases?
Okay, thank you very much for the opportunity to speak to you. I also thank Dr. Moeti and Professor Muyembe. I would just briefly tell you about how the pandemic is evolving in the country and briefly on the variants. As you are aware, we're in our second wave, which started in May up to now. The number of infections have gone up. Currently, we have just above 75,000 reported cases, but I can tell you this is an underestimate. There are quite many who are not reported, who are not in the records, so recognize that. But among the total number of infections that we have, I think about 45% of these infections have occurred in the last few months of about 2 months. So there's, especially May, June. So there's been quite a sharp increase in the number of individuals who have been infected. Unfortunately, this has resulted in a number of people who have passed away, including health professionals. I want to re-echo what Dr. Moeti said. This has put pressure on our health system, including the number of people who require critical care and oxygen. So that is a real big problem. Of course, one of the observations we are seeing is seeing individuals who are in the young age group who are coming up with, again, severe disease. Now, the question is, how have we monitored our variants? As you know, variants, the strains that we have been changing. At the start, when we started sequencing, we identified that individuals last year around March, April, the viruses we have were matching those where individuals came from. If somebody came from UK, the viruses were matching those from UK. If somebody came from US or Middle East, they were matching. And we had a number of strains that were of A lineage, B lineage, A1, B1, different types. As time went on, we also identified a strain that was first described here in Uganda among a cluster of individuals in northern Uganda, and we called it the A23, which later mutated into the A23.1. By the end of the year, this A23.1 was the most dominant, especially in samples collected from Kampala and the surrounding areas. So this was the dominant strain, the A23.1, towards the end of the year. And this variant, although has not been listed among the variants of concern of interest, it has a mutation, the 484 mutation, that at least the Public Health England describes as could be a mutation of interest. Now, at the beginning of the year, 2021, around February, March, when the South African variant had been described, now called the beta, the B1.351, we started seeing individuals who have this variant. That's around February, March. So now we had a mix of the A23.1 as dominant, but also we're seeing the A23, the beta variant coming on. As time went on and more individuals were coming in, at the beginning there was a lockdown, airports were closed, but of course as opening was coming in, other variants that had been described elsewhere, like the Alpha, also became noticeable in the time at the beginning of 2021. So we started also identifying the B1.17. So throughout that period, April, March, we had different variants, the A23.1, the Alpha and Beta, and they were appearing in about the same proportions. But again, slightly with the A23.1. In April, May, again, we realized that we had these variants, but also we noted another variant that now is described as a variant of interest, which was initially called the Nigerian strain, the B1.525, which is, I think, now described as ETA, was also being recognized. So as you can see, we are seeing a mix. Now, towards around April, May, when the Delta variant was described in India, a few weeks after, we identified individuals who had traveled from India. We first had one case in Kampala, then we had a cluster of 4 in Jinja, one of the towns. They were all infected with the Delta. Now, the last sequences that we have had from Kampala, that was the last sequencing on 15th of June. And my colleagues, led by Professor Matt Cotton and others in the lab, now sequencing. But the last report we provided of 15th May, out of 31 sequences from Kampala and the surrounding areas, out of 31, 30 were of the Delta. That's the Indian strain. Now, from what we are seeing, just an eyeball looking at what we're seeing, we are saying the first wave, which we had, That was in around November, December, and the beginning of January this year. The dominant strain was mostly A23.1, the A strain lineage. But in the second wave, we are beginning to see a dominance of variants of concern, including the Delta. Unless we have other sequences that say otherwise, I can say now we are beginning to see a dominance, an increased transmission of the Indian strain, the Delta, from the samples that we previously had. So that, of course, is of concern, and this is the picture other countries are saying, as Dr. Moetti was mentioning, South Africa and the rest, that we are seeing a dominance of variants of concern and variants of interest and an increase of the Delta strain within our sequences, but we shall continue monitoring. I think you requested me to talk about just the variants. I'll not go into the details of vaccinations and the rest unless the audience wants to know where we are with the vaccinations. So I'll stop there.
Thank you, Professor Kaliu. We will surely come back to you with more questions on the response in Uganda. So now, journalists, you have heard from our panelists. It is your time to ask your questions. To do this, please use the Q&A function on the Zoom platform. Give us your name, the name of the media organization you represent. And if you want to go live, please raise your hand. We have in hand Dr. Tiano Balde, who is the team lead for operational partnership, Dr. Richard Mihigo, who is the coordinator for immunization and vaccine development program, and then Dr. Nixie Gumede, who is our regional virologist. They are all on hand to answer your questions. So it is now your time to ask your questions. We are going to start with a question to you, Dr. Moetti, which is from Judith. She's asking, is WHO talking to the European Union concerning the fact that the EU does not recognize COVID vaccine? Does WHO try to push forward so that EU authorities validate it? Do you fear that this problem with COVID might hinder people in Africa to accept being vaccinated? And then the second part of the question will go to Professor Muyembe. It's still from Judith. Many people in Africa refuse vaccination. What is the reason for it in your mind? We start with Dr. Moetti and then Professor Muyembe.
Yes, thank you for that question. Indeed, our Assistant Director General, who oversees the regulatory work of WHO, including supervising the team that's been doing the assessments of vaccines and issuing the emergency use licensing, is very closely in touch with the senior officials of the European Medicines Agency. We provide as WHO this service for all member states, and we are in conversation with them about the situation that leaving the recognition, if you like, of the WHO emergency use licensing is placing African people in. I think these are conversations that have to continue. At the end of the day, it is individual member states who decide through their regulatory authorities whether to accept or not to emergency use license a vaccine, but WHO provides this service for all member states in the world, and we recommend that national regulatory authorities, regional regulatory authorities recognize, take on board the recommendations of WHO, take on the service. Of course, they have their own procedures, but we are hoping that this is a service that can be offered to the whole world to speed up the opening up of travel and to ensure that countries avail themselves of the service that WHO provides.
Thank you, Dr. Moetti. Professor Muyembe.
C'est vraiment une question difficile. Hein? Pourquoi les Africains hésitent à prendre le vaccin? Moi, je pense que dans nos milieux, dans nos traditions jusqu'à présent, c'est le vaccin, c'est pour combattre les maladies de l'enfance. Donc, on donne souvent le vaccin aux enfants. Et les mamans, les papas apportent donc les enfants au centre de santé pour la vaccination, les protéger contre la polio, la rougeole, etc. Mais avec la COVID, on voit que le paradigme a changé. Ce sont maintenant les adultes qui doivent aller se faire vacciner. Ça, donc, je pense que c'est le premier doute. Et maintenant, l'épidémie, la pandémie, survient vraiment dans la période des réseaux sociaux. Et les réseaux sociaux, par de mauvaises informations, amplifient cette peur-là de prendre le vaccin. Parce que vous donnez le vaccin aux jeunes adultes, surtout aux femmes, on parle de la stérilisation, on parle d'autres maladies qui vont venir, ainsi de suite. Donc, il y a une certaine peur, n'est-ce pas, dans la population. Et je ne sais pas, l'information qui est transmise par les réseaux sociaux est vite saisie par la population par rapport à une information que donnerait un scientifique. Et la dernière raison, je pense, c'est le manque de confiance. On a l'impression que la population n'a pas confiance à leur leader politique. On trouve qu'il y a un complot avec les hommes politiques qui introduisent en fait ces vaccins parce qu'ils ont reçu de l'argent, ils ont reçu des avantages, n'est-ce pas, des sociétés pharmaceutiques. Et nous, les scientifiques, comme nous avons été aussi nommés par ces hommes politiques, la méfiance aussi nous concerne. Et souvent même notre message n'est pas accepté par la population. Voilà un peu, d'après moi, les raisons pour lesquelles la population africaine hésite pour accepter, n'est-ce pas, le vaccin pour les adultes. Voilà.
Merci beaucoup, Professor Muyembe. Daniel, your hand is raised. Do you want to go to the question?
Yes, please. Thank you very much. My name is Daniel Arab Moy from China Global Television Network based in Nairobi. My question is to Dr. Moeti. Dr. Moeti, talking about vaccines, is full vaccination an assurance that one cannot contract COVID-19? If not, then how should those who have been fully vaccinated conduct themselves in society? Thank you.
Yes, thank you very much. That's a very good question, particularly the second part of your question, about which we're still learning in those countries that have managed to vaccinate everyone. I think it's important to emphasize that the vaccines don't necessarily stop transmission, meaning they do not stop you acquiring the virus. That's very true of most of them, although there is evidence that in the use of some of the mRNA vaccines may actually stop transmission of the virus. So the main benefit from these vaccines is that they prevent severe forms of the illness. So they stop you getting severely ill and they stop people dying. And this is the way in which we're going to ensure that the national health systems in countries don't become overwhelmed with an impact not only just on COVID-19, but also very much on other diseases as well, as they just crowd patients out of the hospitals. I think that there is there's debate going on in the upper income countries where there are people who are fully vaccinated as to what that means in terms of removing some of the safety precautions. So can people stop wearing masks? Certainly there are allowances being made for people to start gathering indoors. You can stop wearing your masks, start gathering in bigger numbers. I think those are some things that on which we need some evidence. Clearly, some of the strictest prevention measures can be reduced. I think we still need to have a care on protecting those people that are liable to be severely affected if they are infected in our context where we still have people who, we still have the majority of the population non-vaccinated. So I believe that we can trust that we will reduce the impact that we're starting to see in some of the countries where there is resurgence now of overwhelmed healthcare systems. We can start to observe to reduce the measures with a particular attention to making sure that we protect particularly the most vulnerable people, elderly people, people with some of the illnesses that we like to call comorbidities, which make them susceptible to being severely ill and dying of these diseases. And we'll continue to study what sort of precautions can be reduced. We are expecting that progressively we can restore normal life, restore people going to school, perhaps people coming back to work in offices, and businesses starting to reopen in more normal ways so that people can be closer together. But we think that some of the protective measures might still need to be sustained until we get better evidence on this.
Thank you, Dr. Moeti. The next question is coming to you, Professor Kalibu. This question is from Naftali from Shinwa. How severe is the threat of the new variants in Africa, and any mitigation effort in place to minimize their spread? Professor Kalibu?
Okay, I think that's an important question. There's this strain, especially the different strains we're seeing, how are they affecting the severity of the disease? In our context, we don't yet have that evidence. Yeah, the evidence about severity and delta of the disease is still not very clear. There are some indications that it may cause more severe disease, but there are also indications that this may not be a case. So we need to get more evidence. As far as we're concerned here in Uganda, we need to do more surveillance, looking at people who have severe disease and those who don't have severe disease. But at least what has been shown is the increased transmission rates. If you have increased transmission rates, you'll have more people who are infected, and as a result, you'll have more people who will have severe disease. So that means just by it being more transmissible, you are likely to have more severe cases. Not necessarily because it is causing more severe disease compared to the others, because there are more people who are infected. So for the evidence of severity of disease, I think we need to get more evidence. But there are some indications that yes, it could. But the clinical picture has been shown that it is infecting the young population, and that has been shown. Here in Uganda, we need again to get clear evidence, because we are seeing that picture, whether it is really related to this Delta. What I can say, including Uganda, is that the surveillance and the testing and the sequencing we are doing is not adequate. We need to do more. We need to do more working with the epidemiologists. We need to do more working with the clinicians so that we can sample nicely to answer the questions like the one you have raised, which are very important, including responses to vaccines and all that. As far as prevention is concerned, it's the usual prevention. It's the usual measures that Dr. Moeti has mentioned, our SOPs, and the country now in Uganda has really emphasized more, is strengthening prevention, more people. We have using a mask and washing, social distancing, and of course, looking forward to the vaccines. As far as the vaccine is concerned, and the Delta, again, the answer, it may have a reduced effect on infection, but at least the vaccines are working against severe disease, which is good. I think we're trying to avoid severe disease, death, hospitalization. So it's still a good indication. So that's what, in summary, we have. We need to do more. I think the evidence is not very clear, unless colleagues on the panel have any other information otherwise. Thank you.
Thank you, Professor Kalibu. Now we go to Flavia from Uganda Radio Network. Flavia, are you there? Okay, if she's not there, Paul from Devex.
Yeah, hello.
Okay,
Hello.
Go ahead, Flavia.
Yes, my question goes to Professor Kalebu. We are told the number of vaccine studies going on in Uganda. I would like to know the types of vaccines being studied and at what stage we are. I also would like to know from him, there is news going around of fake vaccines that have been given to over 800 people. What would he advise these people to do? And how is this likely going to affect the response? Because people are currently getting their second jabs. Thank you.
Okay, thank you very much. You want to know at what stage, what vaccines are being worked on. As you know, our president and the government has really encouraged scientists in Uganda to develop a vaccine. And this has even become more relevant because of the vaccine nationalism that we are seeing and Africa being left behind. So I think it's an important challenge. But developing a vaccine is not a sprint, it's a marathon. It takes time. I can't tell you when we shall have the vaccine, but I can tell you the three platforms that our scientists are working on, both here at the Uganda Virus Research Institute and at Makerere University. We have colleagues here at Uganda Virus Research Institute working on inactivated vaccine. They are growing the virus in the lab. They have now got some reasonable titers. They're going to inactivate it using chemical inactivation, check in the lab that it's inactivated, it's not infecting the cells, and then work to add the conjugate. After doing all that and they check that it's pure, they are going to work with Makerere University, the College of Veterinary Medicine to start challenges in small animals. And already the facilities for small animals have been set up. Another colleague here at Uganda Virus Research Institute is looking at vector vaccine, looking at two approaches, looking for new adenovectors in our chimps, and some adenoviruses have been identified that can be used as a vector, but also getting some other vectors from other colleagues. And we have already signed some MTA. We are signing some MTAs to get some vectors where we can insert some of our viruses into those vectors. I think it will become interesting since, as you know, the viruses are evolving, so newer products. So that's moving on. And colleagues at Makerere who are more advanced, I think they're moving into small animal challenges. They are looking at a recombinant protein vaccine, again, using the spike region of the virus. And to my understanding, they are working with the colleagues in the veterinary, and they're moving towards small animal studies to look at safety and immunogenicity. So at least the process has started, which is good. Fake vaccines, very unfortunate. I don't know who to blame. I don't know whether you blame the person who gave the vaccine or you blame the people who go into these. First of all, the vaccines are not supposed to be paid for, but I understand they were paying for these vaccines at a certain health facility, which is very unfortunate. And of course, that takes us back. You know, there's been a lot of vaccine hesitance, a lot of negative stories about vaccines. So if you get people who are giving fake vaccines, that puts us back. It's very, very unfortunate. And I'm happy the government is taking very serious steps. These have been arrested. I understand they have confessed, but all these are the people who are buying these vaccines. Why should you go to a health center somewhere in the corner and buy vaccines when the government has told you vaccines are free? I know people are desperate, but sometimes we need to be very careful. So it's unfortunate. During this vaccine, me as a scientist, it has allowed me to interact with many people, including business people, communities, and you can see how sometimes money and profit can really affect good our efficacy. There was a third one, which I'm forgetting. Anyway, let me stop there. But I think there was maybe a third question. Thank you.
Okay. Thank you, Professor Kalibu. The next question is coming to you, Dr. Moeti. This is from Sarah Kimani from SABC News. Strive Masiyawa says the COVAX facility failed Africa by not fully revealing that it did not have enough money to buy Africa vaccines. And that is why the continent finds itself where it is today. What do you have to say? Dr. Moeti.
Yes, thank you very much. First of all, I'd like to say that we are all, of course, concerned and disappointed by the fact that the COVAX facility has encountered these very severe challenges in having access to the supplies that were in discussion, some of which had been in agreement, primarily because some of the main suppliers, one of the main suppliers has not allowed exportation and delivery of the vaccines on which agreement had been reached with COVAX, because that country then started to experience a very severe surge of the pandemic and decided to vaccinate its own population. That's one. And then secondly, COVAX has always made it very clear that it is a multilateral platform for mobilizing resources and for providing support to countries at different levels of, if you like, of income level to have access to vaccines. It's been made very clear, and there have been updates provided to member states. There have been briefings provided to member states to indicate that there have been resource gaps in COVAX. And I think it has also been clear that COVAX is supporting countries not necessarily to reach 100% of coverage. So I believe that there has not been a misinformation or any failure to disclose to countries that there are resource gaps. On the contrary, in conversation with countries, they have been asked to also do their part to mobilize some of the resources that are part of the gap. And we have high-income countries that are members of COVAX to contribute. So I think the information has been relayed to countries in the member state briefings that there are challenges, there are gaps in resources. We need to work together to mobilize the resources. COVAX will be able to support a certain proportion of coverage of populations. And we've been very pleased that the African Union, under the leadership of President Ramaphosa of South Africa, decided to take this initiative of establishing the African Vaccine Acquisition Task Team with the objective of then playing their part and supplementing and looking for the resources and procuring vaccines to cover what COVAX was not able to cover. I think what we can conclude also is that some of the member states, some of the upper income member states of COVAX, at the same time as participating in COVAX, then we're having discussions and procuring vaccines bilaterally and made the global shortage, including challenges of COVAX acquiring vaccine even more acute. But I think that it is my understanding and my observation is that COVAX was providing consistently information to member states in member states briefing that we still have a gap in terms of mobilizing resources. We're looking for more money. I believe that our approach now should be to work collectively to correct some of the challenges or address some of the challenges that are being faced at the global level by every platform that has been established to acquire vaccines for our countries, including in terms of the dose sharing that the upper income member states are doing. And we're very pleased that some of the deliveries from some of this are going to be starting very soon and opening up from some of the vaccines that have been reserved by upper income countries to be procured by platforms that have been set up, for example, those of the African Union. Thank you.
Thank you, Dr. Moeti. Then we go to you, Paul from DEVEX. Please ask your question.
Thank you very much for this opportunity. So my question goes to Dr. Moeti. I would like to know what the WHO's guidance is regarding African countries mixing doses of different vaccines, considering shipments of Astrazeneca vaccine from Serum Institute is not expected anytime soon. And reports of research findings over the release a few days ago showed that vaccines can be mixed. So what is the WHO's guidance on mixing vaccines? Thank you.
Okay, thank you. I'm actually at the moment, the strategic advisory group is examining these questions. I think there is, as you say, evidence that shows that it can be possible to use a different vaccine from a different platform, possibly for a second dose, and to have a good immune response. I'll ask my colleague Richard Mihigo to provide the detailed information about where the SAGE is in determining this question. And I'm sure WHO will soon be issuing guidance to countries on this matter. Richard, if you could come in.
Yeah, thank you, Dr. Moeti. Yeah, I think it's true, as you have said, there is now more and more data that has been compiled in terms of using a different vaccine as a second dose. We have now data that has been published on the use of Astrazeneca vaccine as a first dose and a Pfizer vaccine as a second dose. And SAGE have actually looked at this data and issued even a recommendation, not necessarily to move toward that, but at least a permissive recommendation based on the data that are now starting to emerge. Secondly, there is more and more also data that is being collected, particularly for vaccines that are using the same platform, vector-based vaccine, for instance, using AstraZeneca and J&J vaccine. And I think we will probably see in the next couple of weeks a lot of data that are going to emerge on that. And WHO definitely will be able to provide a firm recommendation on that. So in summary, we could say that for the moment, there is more and more evidence that is showing that using an alternative vaccine, particularly a Pfizer, when you use AstraZeneca as a first dose, is working. There is an increased reactogenicity, but also a better, as we have seen, immune response after that second dose with Pfizer vaccine. So these are rather good news that are starting to emerge and could potentially alleviate the issue of we are seeing now with delays in the shipment of the second dose for AstraZeneca and for allowing people to complete their vaccination series. Thank you.
Thank you, Dr. Richard. The next question is coming to you, Dr. Nixie. This is from Jean from RFI. Can you talk about the variants in Africa? In addition to the variants Alpha, Beta, and Delta, are there some variants, and in which countries? What do we know about those variants? And how do you explain the emergence of those variants in Africa? Is it connected to low vaccination level? Dr. Nixie?
Thank you so much, Miriam. Mary, as you have said that in addition to Alpha, Beta, and Delta variants that has been identified in Africa, we are already seeing other variants of interest that are really coming up, as the Prof from Uganda mentioned earlier on, that they're having a concern of the Eta variant, which was previously known as B1525. This variant has been identified in about 21 countries. As you can see, that it's becoming like the third largest variant that has been reported in the African region after Alpha and Beta. And over and above that, we are also starting to see the Kappa variant, which is a sublineage of a Delta variant, the B1617. This is B1617.1 and the Kappa variant, and it has been reported in 3 countries in the region. And over and above that, also we are seeing the Epsilon. Epsilon is one of the variants that was first identified in the USA, especially in California. And we've got already 2 countries that have reported that variant in the region. The information for this, the reason why they are being called as the variant of interest is that some of this variant, according to the studies, they've realized that they are having a certain mutation that have been seen in the variant of concern. That is why they are under investigation, and then they are trying to find out if those mutations are also going to be showing or making the same particular impact as the ones that are seen in the variants of interest. And then in terms of how to explain this imaging of these variants in Africa, first of all, the coronavirus is an RNA virus, and then the mutation is expected to happen all the time. So even if it's one mutation that is happening in that particular virus, we know that it's no longer 100% similar to the original virus, which was a wild type in this matter. So that is why we're gonna start seeing millions or thousands of these variants coming up, as long as there is a mistake or changes that is taking place during the replication of the virus. So that, can you explain if there's an emergent of this virus and is related to the low vaccination rate? I'm going to echo what the RD has mentioned earlier on, that yes, we can rely on the vaccination, but the spread of the virus is actually caused by the people's behavior. As long as the people are still not complying to the public health social measures in terms of wearing the mask, washing their hands as often as possible, as well as to make sure that they've got very good social distancing. Without that, no matter how much people are fatigued, but WHO is still recommending that people still comply to that. And that's the only way that is spreading the viruses or this variant as much as possible. So everybody is really requested to make sure that they comply to the public health social measures. I think that's it from my side, Mary. Thank you so much.
Thank you, Dr. Nixie. And now we go to you, Esther from Health Policy Watch. Please ask your question.
Thank you very much, Dr. Mary. My name is Esther Nakazi. I'm a journalist with Health Policy Watch. My question is both to Professor Kalebu and Dr. Nixie. I would like to understand from Professor Kalebu, the figures of 30 to 31 that you gave us after the last results you got from UVRI, are they a true representative of what we should understand in terms of this Delta variant? In other words, how much should Africa sequence for us to get a true picture of what is happening in terms of variants going on in Africa? Secondly, I know that Uganda is also sequencing for South Sudan. Are we sequencing for any other countries? And what pictures are we seeing from South Sudan in terms of variants coming out? Thank you very much.
Thank you, Esther. Professor Kalebu?
I think that's a very important question, and which I alluded to, that I think our sampling may not be adequate. We have a protocol that has been developed, working with many colleagues, including WHO and other partners, to do more genomics surveillance. And we have indicated if we implement this protocol, we should go for high transmission areas, low transmission areas, points of entry, severe disease, individuals who have been vaccinated and not vaccinated, to cover quite a lot. Some people have been debating, maybe we sequence about 3% of all the infected individuals. The more you sequence, the better, but in a very organized and systematic way to catch new infections, to catch transmissions, to catch those who are coming into the country, and to look at disease to look at vaccine. But of course, the resources are limited. That's one of the challenges. The resources are limited. Now what we're doing still, the samples we are getting, we are still working with epidemiologists, and they are the ones also helping us to identify. And we have concentrated sometimes in Kampala, where there's a lot of transmission. What you are likely to see in Kampala may give you a reflection of what is going on in the country because of the high infection rates in Kampala. We have also got samples that have been collected in clustered infections where they have suspected there's a cluster of infection. We have also sequenced samples from the points of entry. So although we have not sequenced large sample size as we would have wanted, there has been some logic in the way we have been getting the samples working with our epidemiologists. So in summary, yes, we need to do more, but what we have, especially from Kampala and some of these high transmission areas, may give you some indication. We're going to sequence more. You may find the picture will change. So don't be surprised if we see a different picture. But the more we sequence in a very systematic working with epidemiologists and clinicians, the better. But we have very limited resources. Sequencing is expensive. I'm told now in the GISAID, the global sequence network, global database, Africa is only contributing about 1 out of 300 sequences globally. So we need to do much more. Yes, we are sequencing for other countries. As Dr. Mwete mentioned, there are a number of labs that WHO identified as regional labs to support not only the country, but also the surrounding countries. We have sequenced for South Sudan. So we have just sequenced for Burundi. I've looked at the data. We are also getting samples from Somalia. So that is going. I don't have the current data from these countries. Unfortunately, I should have done so, but I've not checked. But initially, for South Sudan, the area samples that we had, the picture was not very different from what we're seeing in Uganda. The A23.1 was identified, and also the beta or the former South African variant was seen. So I don't have the most recent data from South Sudan, but indeed we are sequencing for that other countries as a regional reference lab under WHO and Africa CDC. Over.
Thank you, Professor Kalebu. So just to inform journalists that we will extend by additional 15 minutes because we have quite a number of questions to still answer. So this question is coming to you, Professor Muyembe. When do you expect DRC to have new doses of vaccine? This is from AFP. And then the second question is, what new strategy is DRC going to apply to increase the uptake of COVID vaccination, given the hesitancy in the country, especially in Kinshasa? Professor Muyembe.
Information que j'ai du ministère de la Santé, on attend 5 millions de doses qui seront en fait un mélange de 2 ou 3 différents vaccins. Et je crois que ces doses de vaccins seront payées directement par le gouvernement. Et on attend donc l'arrivée le 5 juillet, au début du mois de juillet ici. Donc, en ce moment-là, nous aurons les différents vaccins qui vont venir et c'est une des stratégies pour que la population puisse choisir le type de vaccin qu'elle préfère. Et je pense que ça va changer la façon de voir les choses et un peu diminuer la méfiance de la population. Parce que la méfiance a tourné surtout autour de Astrazeneca. Et moi, je crains qu'en ce moment-là, il y aura un engouement tels que les 5 millions de doses ne suffisent pas, même pour la capitale Kinshasa. Voilà.
Thank you, Professor Muyembe. Then the next question is coming to you from BBC, Dr. Moeti. On the situation in Tanzania, we have seen a change of policy, but the government is yet to start sharing data regularly on COVID-19. Is this something you have directly engaged the government on, particularly now that the country has joined the COVAX facility? And what has been the response? And connected to that, is there any timeline and when?
Okay, thank you. First of all, we were very encouraged that the new government of Tanzania, or at least the head of state, took the decision to join the COVAX and therefore to protect the population and protect the neighbors with whom Tanzanians have interactions through travel and otherwise from the COVID-19 pandemic. We are in continuing contact and communication with the government around the totality of the response in Tanzania, including reporting to WHO about data. So we saw the other day that it was shared with the press that there have been 100 cases of COVID-19 in Tanzania recently, but this has not, the formal reporting to WHO has not resumed in that country. Through our country office, through communication from myself to the Minister of Health of Tanzania, and following up on previous communications that we have sent up to the head of state in Tanzania, we're continuing to encourage that country to share with WHO data on a regular basis, as are doing all other member states on the situation in the country. It's on the basis of this that we will be able to inform ourselves how best to provide the support to the response to the pandemic in the country. And most importantly, of course, is part of fulfilling the international health regulations of this member state to its neighbors and to the global public health community to share this information.
Thank you, Dr. Moeti. Then we have the next question from Local Voices in Liberia. This question is coming to you, Dr. Richard Mihigo. There have been questions about using vaccine that are reportedly expired, shortly expired. And given that the availability of vaccine is still of concern in countries in Africa, what is WHO's advice concerning the vaccines that have expired or their shelf life has passed?
No, thank you very much, Mary, for this question. I think we have been quite very clear on this. WHO, we are recommending countries not to use vaccines that the expiry dates have gone beyond the date that the manufacturers have prescribed. So it's true that, and this has been consistent for all the vaccines, antigens that we are using in the EPI program for now more than 2 or 3 decades. But for this particular case, in terms of COVID-19 vaccine that came with a very short shelf life with the expiry date that were short, there was indeed a lot of issues at the beginning. And after all the discussion, particularly when we don't know how the vaccine have been kept, in which condition, I think we clearly recommended country not to use vaccines after their expiry date have passed.
Thank you, Dr. Richard. Now we go live to Felicia Uma. Are you there?
Oh, yes, yes, I am there. Thank you so much. I am Felisa Uma from Radio Patches in Gulu City, Uganda. Well, my question goes to Kalebu, Dr. Kalebu. I want to know about COVIDX because recently the National Drug Authority approved the use of Covidex as a supportive treatment for COVID-19 in Uganda. So I would like to know from Dr. Kalebu, how trusted is data Covidex? Because it's still new and we don't understand it well. So how trusted is that? Because now I see people are really, running for it, and the prices are even increasing. Like there is a man here in Gulu who is saying that he's selling it at 35 or 40. So how can we trust that? Yes, that is on Covidex, the new supportive treatment for COVID. And then also, but still on that, I think I think I has already answered this question. Let me not answer it. Ask it. Sorry. There is this one question on the fake treatment, the fake vaccination, because as my other colleague mentioned earlier on about the fake COVID-19 vaccination, about 800 people in Uganda received fake vaccination for COVID-19. So now, how can we trust our health centers in the different cities and the different districts in Uganda about the different health centers? Because the people are going to receive vaccination from those health centers. How can we now trust that they are giving us the rightful vaccination? Because we are not doctors and we don't know that. And then maybe another question that will now go to Dr. Moeti. Yes, I want to know whether Astrazeneca only fight a particular variant of COVID-19. Does Astrazeneca really fight all the variants, the emerging variants, and also those ones that really came earlier on, like that one from India, China, and the rest? So I want to know whether all the variants, the Astrazeneca can really fight all the variants. And and then finally, to Dr. Moeti, I also want to know when should we expect vaccines for the young children? When should we expect that? Because we know now the new variants are not actually sparing the young ones. The young ones are also getting the new variants, and also the old ones. They are now getting affected, and many young people and the old ones are also dying now. So when are we receiving vaccines for the young people? Thank you so much. Regards.
Thank you, Felicia. We start with Professor Kalibu first, and then Dr. Moeti can come on with the questions on vaccine, and Richard can complement.
Okay, I think Covidex. Covidex is a drug. It's a herbal medicine that National Drug Authority has approved for use as supportive treatment. I think people should not confuse that this is a cure for COVID. It's not an antiviral. Yeah, it is supportive. Yeah, it is made of herbal medicines that have been traditionally used before. I think it can help you with the respiratory tract and all that. I think we need to be careful the way we advertise and the way people are going to make business by not sending the clear message that this is not a cure. If you are sick with COVID, go to the right medical doctors to manage you. Don't stay at home that because you are using Covidex. It may help you supportive wise, but it's not there. You have to go to a right medical health facilities who are going to manage you. For us who have been here longer, we saw a lot of this. There's sometimes excitement. When there's no cure, of course, anything that comes, especially to help you to live better life and all that, will be welcome. But I think the danger is to misinterpret it and label it differently as if it is an antiviral or a cure, but this is supportive, which is okay. And the supportive medicine has been used even for other infections. So I think NDA, whereas they have given the approval, they should work with other regulatory bodies to ensure that it is marketed in a proper way so that it doesn't confuse people to rush and to avoid medical care and to sell it expensively. It's a herbal plant. I don't have personally, I've not read the details. All I've also heard is like you from NDA, but I'm very keen. I'll try to get more information on the data that is available that led to the NDA's approval. I'm equally keen to read around it and understand it, but the fact is that it is not a cure, it's a supportive treatment. That's what NDA has said. It's a traditional herbal medicine that has been put together. Fake vaccine, as I said, very, very unfortunate. Yeah. And the ministry, I think, is coming out very firmly and strongly, together with the other enforcement agencies, to see how this can be stopped. But I think it's all of us, all the health workers, medical ministry. I think it's all our responsibility to ensure that we at least put a stop. We don't encourage this, so that otherwise it will put us back to vaccine hesitancy, and people really are moving away and avoiding vaccination, which will be terrible and bad. So I hope this does not happen again, and it's very, very unfortunate. Let me stop there.
Thank you, Professor Kalebu. Dr. Moeti?
So first, the question about the effectiveness of the Astrazeneca vaccine against different variants. I mean, certainly a relatively small study in South Africa showed that it had reduced efficacy against the beta variant, especially I think there was inadequate data in terms of if it really prevents infection, and certainly that it is reduced in terms of efficacy in stopping or preventing severe disease that would progress to death. I understand that from data that it's against the Delta variant, it is effective at a level of about 67%. Certainly this is lower than the efficacy of, for example, the Pfizer vaccine, but it's a level of efficacy that I think would enable it to be useful and to be used in countries where this variant is circulating. So we would say that we can still use the AstraZeneca vaccine in countries where we see the Delta variant, but there has been a decision, as we know, by the South African government not to use it at the time when the Beta variant was very, very predominant in South Africa. So that's the information there. And then the question about when should we expect vaccines for young people? I think we need to study the data about young people being infected and be very clear who we mean by young people. Certainly, and when we see younger age groups, so for example, there's data from some countries that people at a younger age than the 60s and upwards that have been observed in many countries. In African context, we see people in their 50s sometimes becoming severely ill and dying of COVID-19. Countries then can adjust the minimum age at which they start prioritizing those who are to be initially vaccinated in the highest priority groups. I think we're also seeing, though, in some countries, the question of whether young people, children below the age of 12 years should be vaccinated. And I think it's very clear that these are groups for whom infection with the COVID-19 does not present a high risk of severe illness, and vaccinating people of that age would be in terms of trying to limit the spread of the virus to other people. So this question should be looked at in that context. In Africa, of course, we have in some of our countries a high prevalence of HIV, which compromises the immune systems of people. And we need to study the data and see that among young people at higher risk of HIV, where the access to antiretrovirals might be lower and people's immune status might be compromised, will this make a difference? And should countries then look again at when to start prioritizing people of a certain age group? Overall, of course, we know part of the reason for giving vaccine to a broader and broader age range is to use the vaccines to limit the onward spread from younger people who may be infected, not getting very seriously ill, but are able to transmit the virus to other people if they're not vaccinated. Certainly, and just to refer to a question that was asked earlier, the vaccines, even if they don't stop you being infected, will reduce the rate at which people who have been vaccinated will transmit the virus to others. So this is the way in which we're going to eventually reach so-called herd immunity, and also the way in which, by reducing the transmission, we are going to reduce the chance of the emergence of variants. Thank you.
Thank you, Dr. Moeti. Dr. Richard, anything to add before we wrap up?
Yeah, maybe just very quickly on the first question on the efficacy of AstraZeneca against the variants, and even beyond AstraZeneca, we are now more and more data that are starting to come from vaccine effectiveness studies. These are the studies that are looking at the true performance of the vaccine in the real life when the vaccine are rolled out in a large proportion of the population. And as different from the data that come from a clinical trial. And what we are starting to see in those large vaccine effectiveness study is that clearly AstraZeneca vaccine against alpha, beta vaccine, and even delta, in terms of preventing severe disease and hospitalization, I think we have a very good performance of these vaccines. So I think, and I think we've been saying this in many different conference press. I think one of really the objective of these vaccination drives that country are conducting, it's really at the end of the day to make sure that we are preventing really serious illness, we are preventing hospitalization, and ultimately we are preventing the death of the people from the disease. And being AstraZeneca, but also other vaccines that have received WHO EUL, the emergency use authorization, they are all performing quite very well when it comes to preventing severe disease and hospitalization. Thank you.
Thank you, Dr. Richard, for that addition. We are now coming to the end of the press briefing for today. So I'll give our panelists 1 minute each, starting with Professor Muyembe to give us their final thoughts. So Professor Muyembe, then Professor Kalebu, then finally Dr. Moeti. Okay, I can see Prof is muted. Let me go to you, Professor Kalebu, first.
Okay, I think thank you for the opportunity. I think the only message I can give, of course, it's unfortunate that in Africa we are seeing an upsurge of infections. Some countries seeing second, third wave. I've been mentioning that without enforcing the prevention, ensuring that we prevent the SOPs that are available, that have been given us to use, I think we are likely to see a continuation of infections and coming up with variants. And sometimes the variants could become even more severe, more transmissible, and then we continue with the pandemic. I think for now, before the vaccine becomes widely available, we hope we shall have the vaccine. Let's make sure that we keep to the SOPs, but also we thank WHO and other partners and the governments that increased the effort to ensure that our hospitals are equipped to manage our sick ones so that we don't lose more people. It's unfortunate we're losing a few, some of our citizens. I think we should ensure that we provide the care so that people don't die, and we need all the support from our governments and all the partners. At the same time, let's try to prevent transmission and also make all efforts to see that the vaccines become available. I think the clear message that is coming out, the vaccines that we have at least are effective in preventing death, severe disease, and hospitalization. So the message is, let's keep to our SOPs to avoid more infections and coming up emergence of additional variants. Thank you.
Thank you, Professor Kalebu. Professor Muyembe, are you there? Professor Muyembe, you're muted. Okay, so let me go to Dr. Moeti then for her final thoughts.
Thank you, Mary. First, I'd once again like to thank sincerely Professors Kalebu and Muyembe for having joined us and shared with us and our colleagues, the journalists, information about variants in their two countries. And then to conclude, would like to say that we hope sincerely to see the resumption of vaccine delivery to our member states. We have all been working extremely hard to play our different roles to make sure that the vaccines are available. We appreciate the offers of dose sharing from countries that have more doses than they need for their populations. And we just like to urge that this be accelerated in terms of the actual delivery to our countries so that they pick up again on the campaigns that they were running. And then finally, that we are working very hard as WHO at the country level, supporting from the regional level to make sure that the state of readiness of African countries when the vaccines start to arrive, and we're quite confident that the vaccine availability is going to be increasing in the next few months, is such that we use every single dose of vaccine that's available, we deliver it to people, and we start to have an impact on the wave that we are seeing of the pandemic in African countries and spare people. Finally, to say all of this is depending on all of us. It is still necessary in most of our countries to continue with the public health measures of wearing your mask, washing your hands, keeping a distance, not going to big gatherings. And we encourage people very much to continue to have the patience. And finally, if you have the chance to have a vaccine, if there is vaccine available and you are in the target group, please go and get vaccinated for your own sake, for the sake of your family, for the sake of your community, of the economy of your country, and to enable us to start to get back to normal life. Thank you.
Thank you very much, Dr. Moeti. We have now come to the end of our press briefing for today. A very big thank you to our panelists for the interesting discussions, and then thanks to all the journalists that have joined us today. We still have colleagues, Dr. Richard and Dr. Tiano Baude, that will answer some questions in French. So thank you and have a nice day. See you next week.
Thank you very much. Thank you. Bye-bye.
Bye.
Merci beaucoup, Dr. Stephen, et bienvenue à tout le monde pour cette partie de la conférence de presse entièrement en français. Comme il a été annoncé, comme d'habitude, avec nous, il y aura le Dr. Richard Mihigo, coordinateur du programme de vaccination et de mise au point des vaccins, et le Dr. Tiano Baldé, qui est chef de l'unité des partenariats opérationnels. La première question sera pour Dr. Mihigo. Elle nous vient de Marthe Bossuant-Dolé de l'AFP en RDC. Voici la question. L'Union africaine a récemment protesté contre le fait que l'Union européenne, dans le cadre de l'instauration de son pass sanitaire, ne reconnaisse pas le Covishield, qui est donc la version Astrazeneca fabriquée en Inde et largement administrée en Afrique. Quel commentaire fait le bureau de l'OMS en Afrique sur cette position de l'Union africaine et quel impact peut avoir l'attitude de l'Union européenne sur les campagnes de vaccination en Afrique? Dr. Richard Mihigo.
Oui, merci beaucoup. Nous avons reçu effectivement beaucoup d'interrogations sur cette directive de l'Union européenne qui entre d'ailleurs en vigueur aujourd'hui au 1er juillet. Clairement, comme l'a souligné l'Africa CDC, l'Organisation mondiale de la santé également déplore cette décision parce que nous estimons que les vaccins qui ont reçu l'autorisation d'utilisation en urgence par l'OMS sont des vaccins autant valides que ceux qui ont été approuvés par l'Agence européenne des médicaments. Le processus qui est utilisé par l'Agence européenne des médicaments est exactement le même que celui que l'OMS utilise. Mais il faudra comprendre une chose, c'est que très souvent, les vaccins qui sont autorisés par l'Agence européenne des médicaments sont des vaccins qui sont a priori d'abord destinés à être utilisés dans l'espace de l'Union européenne. Mais comme Astrazeneca est un seul vaccin qui est produit sur différents sites, que ce soit au Royaume-Uni, en Europe, mais également en Corée du Sud, au Japon, aux États-Unis, en Inde pour le cas de Covishield. Nous pensons qu'après la qualification de l'OMS, l'homologation de l'OMS pour ce vaccin, la plupart des pays devraient, et c'est l'appel d'ailleurs que Dr Moiti a fait tout à l'heure, reconnaître ce vaccin. Alors, les choses, je pense, que bougent un peu. Nous avons vu ce matin des informations comme quoi 7 pays déjà de l'Union européenne ont autorisé, homologué en quelque sorte le Covishield, y compris la Suisse, qui n'est pas membre de l'Union européenne. Et nous pensons que, comme on l'a dit, et d'ailleurs, comme le Conseil de l'Europe a été très clair en disant que les pays, ils demandent aux pays également de l'Union européenne de reconnaître les vaccins qui ont reçu l'homologation de l'OMS. Nous espérons que cette situation va se décanter dans les jours à venir et que nous allons mettre derrière nous cette situation. En termes des conséquences, bien entendu, ceci a aggravé un peu la méfiance que certains pays ou populations avaient contre ce vaccin Astrazeneca, mais nous pensons que nous allons mettre cela derrière nous et aller de l'avant.
Merci beaucoup, Dr Mihigo. Je me tourne maintenant vers Dr Baldé pour une question de Falila Gbad-Damassi de France Info. Dr Baldé, que préconisez-vous pour la gestion des flux de voyageurs nord-sud dans un contexte maintenant où les touristes originaires des pays les plus riches peuvent désormais voyager aisément et décider par exemple de venir en Afrique où les populations, elles, ne sont pas immunisées?
Oui, je phénomène auquel donc il faudrait s'attendre compte tenu de la dynamique évolutive donc de cette épidémie-là et définitivement la sécurisation aussi des pays où actuellement donc le taux de vaccination est relativement faible est un élément très très important. Et dans tous ces pays-là, nous encourageons à l'adoption et au renforcement de toutes les mesures donc de santé publique et puis donc de distanciation physique qui nous permettent un peu d'éviter un peu la propagation exponentielle que l'on voit un peu de cette maladie dans certains endroits. Donc, je crois qu'ils viennent ou qu'ils ne viennent pas, il y a lieu ici de reconnaître et d'appeler ici tous les pays actuellement donc à un renforcement de ces mesures-là. Et que si ces personnes-là arrivent, qu'ils suivent vraiment les protocoles qui sont en vigueur dans ces pays-là, donc en venant avec des tests qui sont négatifs, donc des tests PCR qui sont négatifs, et une fois rendus aussi dans ces pays-là, donc de pouvoir adopter donc ces mesures-là qui permettront de protéger les différentes populations. Donc, c'est une dynamique, je pense, qui change en fonction des contextes. On a vu donc une suppression ou on va dire une levée de beaucoup de restrictions dans les pays donc, qui sont relativement avancés en termes donc, de vaccination, mais ce n'est pas encore le cas dans les pays africains. Donc, je crois qu'on appellera à la vigilance et donc des pays, mais aussi donc au respect de ces normes-là par les personnes qui voyageraient donc des pays du Nord vers les pays du Sud. Donc, c'est un appel véritablement que l'on lance. Donc, nous, on est encore dans une phase extrêmement sensible, extrêmement difficile, comme il a été mentionné tout au long de cette conférence de presse-là. Et nous appelons vraiment au respect de ces règles, de ces mesures-là, donc, dans les différents pays, y compris de la part des personnes qui viendraient donc de pays où le processus de vaccination ou encore les immunités acquises sont beaucoup plus importantes que dans notre région. Merci.
Alors, vous venez d'évoquer les mesures barrières, les gestes barrières. La prochaine question, justement, est sur le sujet. Jusqu'ici, ces mesures barrières ont préservé le continent, mais pourquoi est-ce qu'elles ne suffisent plus? Qu'est-ce qui a changé actuellement?
Il faut se dire qu'il y a plusieurs phénomènes donc, qui sont associés à cela. Déjà, la durée un peu de cette pandémie-là, ça fait maintenant plus d'1 an et demi que cette pandémie-là, elle perdure dans notre région ici et dans le monde entier, on va dire. Et donc, l'adoption de ces mesures-là qui sont relativement contraignantes quand même, donc entraîne un certain état de fatigue de la part donc, des populations et de la part des communautés. Donc, ça, c'est un premier élément qui expliquerait cette situation que l'on voit actuellement. Le deuxième élément, c'est que aussi les pays les plus affectés sont les pays donc, qui sont situés au niveau donc, de l'hémisphère sud, donc les pays donc, d'Afrique australe qui sont actuellement en phase quelque part donc, d'une saison un peu plus froide, je ne dirais pas hivernale, mais en tout cas une saison un peu plus froide, qui expliquerait un peu plus donc, cette sensibilité, cette susceptibilité des différentes populations donc, à acquérir donc ce virus-là et à développer certains signes, y compris des signes sévères. Et le troisième facteur, c'est évidemment donc la circulation concomitante d'autres variants donc de ce virus-là, qui sont notamment le variant Delta, qui a une transmissibilité qui est beaucoup plus importante, donc qui explique ces événements-là. Donc, mais ici à l'Organisation mondiale de la santé, évidemment, on essaie donc de suivre, de faire un monitoring véritablement très, très précis de l'évolution de cette dynamique-là et d'ajuster l'appui que nous donnons au pays donc en termes de matière de réponse. Et pour finir, effectivement, donc pour pouvoir compenser actuellement ces déficits que l'on a, ces limites que l'on a en termes de vaccination, comme l'a dit les autres panélistes, il y a lieu de renforcer donc les mesures sur lesquelles on a une certaine emprise, donc avoir de meilleures capacités de traitement qui pourraient être à l'échelle, donc qui pourraient être contextualisées à nos contextes, à nos systèmes de santé ici, et aussi pouvoir donc avoir d'autres mesures aussi, des mesures communautaires, donc pour pouvoir encourager les gens en leur donnant les outils qu'il faut, évidemment, donc pour pouvoir adopter ces mesures barrières-là. Merci.
Merci, Dr Baldé. J'aimerais maintenant me tourner de nouveau vers vous, Dr Mihigo, pour une question concernant la production de vaccins. La question est la suivante. L'Égypte, le Sénégal et l'Afrique du Sud devraient produire des vaccins contre la COVID-19 bientôt. Pourriez-vous faire un point sur la situation?
Bon, les choses n'ont pas beaucoup changé depuis notre dernière mise à jour. Je crois que pour l'Afrique du Sud, nous avons le lancement de ce hub sous-régional qui va être un pôle d'excellence pour non seulement le transfert de technologies, mais également la formation des autres pays pour la production future de vaccins à ARN messager. Mais entre-temps, nous savons qu'au niveau de l'Afrique du Sud, avec la firme Aspen Pharmaceutical, qui est entrée en contact avec la firme Janssen pour le vaccin de Johnson & Johnson, les activités de production vont déjà démarrer. Et d'après ce que nous avons cru entendre, les premières doses devront être produites d'ici avant la fin de l'année. C'est déjà une très bonne nouvelle pour le vaccin de Janssen, Johnson & Johnson. Nous avons également des informations sur la production en Égypte du vaccin de Sinovac et celui de Sinopharm au Maroc. Donc, il y a déjà des choses qui se mettent en place pour aller de l'avant dans la production locale de vaccins au niveau du continent africain. Mais sur le court et le moyen et le long terme, je pense que la mise en œuvre de la politique qui a été lancée par l'Union africaine de la production locale de vaccins reste quand même un objectif qui devrait se matérialiser et effectivement se mettre en place pour une sécurité sanitaire sur le long terme.
Merci. Je reste avec vous pour une question un peu différente, mais toujours concernant la vaccination. Face à la pénurie de vaccins, pourquoi ne pas les administrer comme dans le cas d'Ebola, où l'on vaccine la zone où un cas a été repéré?
Oui, effectivement. Dans le cadre d'Ebola, nous avons fait ce que nous avons appelé le ring vaccination, ou bien la vaccination en cercle, parce que simplement, on n'avait pas beaucoup de cas d'Ebola et il était plus facile lorsqu'on avait isolé un cas d'Ebola de rechercher les contacts et de vacciner les contacts et les contacts des contacts. C'est ce que nous avions appelé la vaccination en boucle ou le ring vaccination. Mais pour ce qui concerne la COVID-19, la situation est complètement différente parce que la transmission, elle est déjà communautaire, elle est élargie. Il est extrêmement difficile de savoir qui est infecté et qui ne l'est pas parce que malheureusement, avec cette maladie, on peut avoir la maladie et rester complètement asymptomatique, mais tout en continuant à transmettre la maladie. Donc, c'est la stratégie de vaccination en boucle ou le ring vaccination ne peut pas malheureusement s'appliquer à la COVID-19 parce qu'il est, comme je l'ai dit, extrêmement difficile d'appliquer les mêmes principes d'identification des cas, d'identification des contacts et de vacciner tout ce monde pour essayer de boucler la transmission. C'est complètement différent et ici, il faut mieux prévenir et vacciner tout le monde, en tout cas les populations éligibles, pour éviter effectivement que cette transmission ne continue à s'élargir vers des groupes autres que ceux qui sont déjà affectés.
Merci beaucoup, Dr Minigo. Et pour la dernière question, je me tourne vers Dr Baldé. Depuis plusieurs mois, l'OMS alerte sur la menace d'une résurgence de la COVID-19 en Afrique, à l'image de ce qui s'est passé sous le sous-continent indien. Estimez-vous que les États vous ont suivi, ont été attentifs à vos recommandations?
Oui, je pense qu'il y a de nombreux efforts qui ont été faits dans tous les différents pays et on continue le travail de sensibilisation et d'information à différents paliers des organisations, donc à un niveau régional, à un niveau sous-régional, mais aussi à un niveau national. Donc, cet exercice-là est en cours et il porte ses fruits parce que l'on voit ici aujourd'hui le sérieux avec lequel beaucoup d'États aujourd'hui sont en train de s'engager. Le docteur Mouetti l'a dit tout à l'heure, pour l'acquisition des vaccins, on vient d'entendre les collègues donc, de la RDC, de ce qui est anticipé, ce qui est attendu d'avoir donc dans les prochaines semaines. C'est le cas un peu partout dans les différents pays là. Et aussi la préparation que nous accompagnons en tant qu'OMS, donc la préparation opérationnelle, autant pour la prise en charge, les aspects de prise en charge, autant donc pour les aspects aussi d'engagement communautaire, mais aussi les aspects de vaccination. Donc oui, il y a une certaine ouverture, il y a beaucoup d'ouverture et beaucoup donc d'attente aussi donc de la part de ces pays-là pour pouvoir donc courber ou en tout cas impacter sur la dynamique évolutive de cette épidémie-là. Et nous anticipons de cela beaucoup parce qu'ici on classe généralement nos pays en 3 différentes catégories, des catégories donc de pays qui sont en résurgence, donc qui font face à cette 3e vague-là actuellement, mais aussi on a des pays donc que l'on observe qui sont en alerte, donc dont la plupart du temps donc bougent en quelques semaines de cette phase d'alerte-là à une phase donc de résurgence, et puis des pays aussi que l'on garde un peu sous les yeux, qui sont en train aussi donc d'aller où quand il y a des événements, on voit vraiment un rebond du nombre de cas avec des facteurs explicatifs. Là, on essaie vraiment d'enclencher la machine et de pouvoir donc alerter et puis les supporter dans ce sens-là. Donc, je pense que c'est un exercice qui est en cours. Ce n'est pas quelque chose de simple, ce n'est pas quelque chose de facile, c'est un exercice relativement complexe, mais je pense que les efforts des uns et des autres, je pense, on arrive au moins à faire ce que nous pouvons faire et ce qui est à notre disponibilité, à notre disposition. Merci à vous.
Merci beaucoup. Nous avons fait le tour des questions. Merci beaucoup, Dr Richard Migo. Merci, Dr Tiano Baldé. Et merci aux journalistes qui sont restés un peu plus longtemps pour écouter vos réponses très complètes. Merci beaucoup et à la semaine prochaine.
Merci, au revoir. Merci.
OK, merci et à la prochaine. Au revoir.